Hello, everyone. Good morning. Really excited for the conference this year. My name is Aviana Baldwin. I'm one of the PGY4s here. I will be applying into spine surgery next year. To start off this morning, we have a little bit of a spine trauma combo, so everyone should be excited, listen up, and I think there's some great tidbits here to learn. Okay, so our patient here today, we have Jo. She's a 32-year-old female who had a 4-story fall, sustained somewhere else. She was airlifted to another outside hospital. And she was a polytrauma patient with her initial injuries being a vertically unstable pelvis fracture that underwent fixation 3 weeks later at the outside hospital. That possibly, given the report was complicated by some infection, maybe underwent an IND. And then also she had a left calcaneus fracture that underwent ORIF at an outside hospital as well. So here, we do not have her injury films. However, we do have these immediate post-op fixation films. And given it was done in an outside hospital, we can Monday morning quarterback a little bit and go through the fixation to start us off here. So what we can see is that she's had pubic symphysis fixation with an anterior column screw, and then she's had S1 and transsacral transiliac fixation. And so looking at these images and looking at, and I have closer up views as well, Dr. Schmidt, in terms of judging an acceptable reduction for these vertically unstable pelvis fractures, would this be an acceptable reduction to you? And if so, do you have any concerns here about the reduction and or the fixation chosen?
Yeah, it's hard to just judge post-reduction views without having the injury views to see kind of what the initial displacement was. Clearly, it's not perfect. I see some residual displacement in the left sacral fracture. It looks like one of the screws may already backed out a little bit. It's hard to tell the shorter screws. So there's a transsacral screw and another screw into S1. It looks like. But it's not perfect. And what I think bothers me the most is the inlet view, where you can see the ischial spine and just not symmetric. The iliac wing still looks externally rotated. So there's clearly malreduction. The symphysis looks pretty good. We've not been a big fan of the anterior column screw. Our place, we occasionally use them. But it's hard to know. So this is the immediate post-op view, isn't it?
So this is immediate post-op. Just a few weeks after.
Yeah.
Then I have also just some closer, just to kind of.
Everything was done percutaneously.
We don't have the operative reports. It seems like maybe open, of course, in the front, maybe, and that's where she had her IND, but in the back, possibly percutaneously.
So I know at our center, Dave Tuppelman and Emily Wagstrom are the ones that really fix these. They'll often resort still to open posterior approaches for some of these more complicated ones where you can't get a reduction. But that's the whole trauma, or the whole controversy, I think, in these fractures, is what actually is an acceptable reduction. This is probably is acceptable. It's certainly not perfect.
Okay, so you're done with this, and it's not perfect. You say, okay, we're leaving, and I'm not going to change this.
Actually, this outlet view, actually, when you look at the sacrum here, it's still, there's a lot of residual vertical displacement too that you appreciate best on this, especially more cranially at the L5S1 junction. So, you may need a CT to better evaluate exactly what's happening.
Mm-hmm. Okay, so she now presents to us, and this is where we in the spine service and our multidisciplinary approach get involved. Mm-hmm. So she's 8 months after injury, and she's mainly presenting with left buttock numbness, lateral thigh, leg, and forefoot numbness, and then she has 4 out of 5 strength in her tibia and 3 out of 5 in her EHL. And then on top of that, she has a lot of anxiety and depression surrounding her decreased function, even though she has been able to return to work and walk. Given that she's a younger person, she's not functioning the way she wants to. She's on gabapentin antidepressants, no narcotic use at this time. And then thus far her interventions have been, physical therapy, yoga, meditation, things of that nature. And so this is, a little bit more of a general to the residents question. At this point, you have this patient, you have a patient with a pelvis fracture. What is her diagnosis, or what are you concerned about? Anyone can shout it out.
We could have compression on the L5, based on these symptoms, would be localizing likely to the L5 nerve root. So you could have compression from the fracture, from something in the lateral recess at the L4-5 level, or in the foramen at the L5 level. So there could be multiple locations.
Exactly, and that's what we're concerned about. L5, she's presenting with an L5 radiculopathy, just like you said, Dr. Wiggins. Thank you. And like we said, this can be injury.
Can I interrupt for a second here?
Thank you.
Sorry. So I think it's very helpful to ask the patient what they're most concerned about, what their true chief complaint is. Often people with just numbness aren't, and depressed about the numbness. Can you give me any clarification on what was the thing that concerned her the most when she presented to you?
Yeah, so it appeared to be the weakness and the fatigability. So her not able to function at the level she was before because she would had weakness, like she was perceiving or experiencing now weakness. And then I would say the secondary symptoms were the buttock numbness that she was also experiencing.
So functional loss, ability, decreased stamina, decreased ability to walk, those kinds of things?
Yes.
Okay, all right, very good. Can I ask the residents a question? Who here is a PGY2? Anybody? PGY2?
Raise your hands high.
All right, so we see that, okay, I see a hand back over there. So somebody mentioned, one of your colleagues said L5, right? So we have EHL and anterior tib weakness. What other key motor strength should you evaluate when you're thinking about L5?
So with L5, or concern for L5 radiculopathy, would definitely do like a full lower extremity exam, but in this case would test for TIB-ANT, EHL. I would test like my FHL, would do I would do like a sensory exam
Anybody
as well.
want to help them out?
Sure.
Any of the more senior residents, another major motor group, when you're going to see this when they walk? Go ahead.
Yeah, Trendelenburg.
Very good, the abductor. So that gets often overlooked. So you examine them post-operatively, you check their EHL and anterior tib almost always, but you hardly ever check the abductor muscle group. So just think about that, and you're gonna just a quick way to do that evaluation is just see how they walk, single leg stance.
And to add on to that, in terms of what is happening with L5, we know it can be injury-related, as Dr. Wiggins was saying, in terms of associated with a fracture. Instrumentation-related, as Dr. Schmidt was alluding to, wants to see a CT. Or it could be unrelated. I will note that for her, she had no prior symptoms prior to this pelvic injury, so most likely not unrelated to the injury. And we kind of already spoken about, Dr. Wiggins have already given us some levels of compression that we would be thinking about also in terms of localizing the lesion. Yes.
Were there full spine films taken at the outside hospital at the time of her injury? And is it documented that there's no injury in the lumbar spine?
That's a good point. There was noted a possible TP fracture, like a transverse process fracture, and then maybe a note of maybe a non-insignificant L2 compression. But in terms of from these images, we do have lumbar films. There's nothing of note that we're seeing. But yet again, these are the post-op, but I would presume the lumbar spine would be similar to the immediate post-op pelvis films.
It seems like her pelvis fracture's healed. She's walking 5 miles, but does she have any other symptoms of a malunion, such as a asymmetry in her gait pattern, sitting imbalance, anything else that might indicate a symptomatic malunion of her pelvis above and beyond the neurologic symptoms?
No, it was mainly in terms of the posterior symptoms were mainly numbness related. They weren't, like you said, pain or related per se. And so now we've gotten a CT, and this is when she's come to us 8 months after injury. And so things we want to essentially evaluate in the CT is ensuring that we have safe position of the screws, which is evident from these images. And then also is that her fracture is healed. So we know she has a malunion, but and so, like you were alluding to, Dr. Schmidt, we're not necessarily worried that she's having symptoms from the pelvis itself here. So these were just videos in case those didn't come up. Okay. So now we're, one more. Okay. So now we're at the point where what should we do with her? We're thinking about our further testing. So we then proceeded to get an EMG, an MRI, and also referral to our peripheral nerve clinic. And then in the meantime, she's doing physical therapy. Anything else either of you would have additionally done besides get the CT to ensure that the fixation and healing and get these consults?
Dr. Yuna saying x-rays, that's always good.
X-rays.
I mean, it sounds great that you have this interdisciplinary clinic. We don't really have that at my place, so these are difficult. But the neuropsychological testing too, to understand the interplay between all the mental, emotional, mental health aspects of this is important too.
Yeah, that's actually a great point. She actually had a lot of PTSD from the accident, and she was actually at the same time seeing a therapist for that as well in a group. And so the EMG is not extremely helpful. It's, the summation of it is there's a chronic left lumbar sacral plexopathy that is difficult to localize. So, we know there's something going on, but we're still not necessarily clear about the level. We have a neurogram, and I saved us all from the images because it's just artifact. I'm very surprised that there was a radiology read, but the radiology read essentially says there might be some scar, granulation tissue, perivertebral swelling, kind of very non-distinct, but we can't really see anything because she has those posterior screws. And then our peripheral nerve clinic, given her exam and her symptoms, there's a question of, is there an underlying lumbar plexus sciatic nerve compression and/or compression at the L5 nerve root? And the question is posed as, is there a double crush component? And so the question is, we still haven't identified we still haven't localized her primary problem to see what the operative intervention is. And so for us, the next step that we said was, okay, we've confirmed, we got of course, another trauma colleagues involved, in terms of the trauma clinic as well. I didn't include that aspect, but spine and trauma is also seeing her. And so we said, okay, we need to remove the hardware in order to proceed with further images so we can actually see what is happening a little bit better.
I'll interject here. So maybe for Sam, who I sent this patient to, is there any concern with a fracture like this? So the fracture goes through the sacrum, so we can get a bony union, but any concern about secondary or late displacement or any sequelae of taking out instrumentation in this case?
That's good. Good to see you. I mean, taking out hardware from the pelvis is always fraught with potential complications. You can, I mean, I'm not seeing evidence of a non-union. I'm not seeing, I'm not seeing hardware within the neural foramen, but I've certainly taken out hardware like this and gotten into the superior gluteal artery and other potential vascular complications. The hardware can break. That's always something I advise patients on, and I tell them if that happens, if a screw head comes off, we're not going to go, coring out half the pelvis to get the hardware out.
Just one little tidbit. I recently reviewed an article as part of my maintenance of certification on hardware removal. And the only hardware removal that was statistically correlated with a higher rate of complication was removal of hardware from the pelvis. Not surprising, but confirmed by the data.
So now we're proceeding, and Dr. Yoon, we have X-rays. I know this entire time I disappointed you, but we have some alignment films, and overall there's overall balanced coronal sagittal alignment. No concerns from that aspect, which we weren't concerned about, but it's always good to check as well. And then, so now these are snapshots from the CT post-heart removal that we're seeing. And of note, what we're seeing here is there appears to be heterotopic bone formation within our L5S1, within our L5 foramen. That is therefore would be concerned that it, oh, sorry, I'm using my mouse, but not this one. Okay. There would be our heterotopic bone ossification here, and then here. That is compressing our L5. Now the question is, where is the nerve located in all of this? And so we then proceeded with an MRI. And so the key difference here in this MRI, you can see above is 4-5, and you can see that foramen appears to be very open. And the level below, we're unable to really, make out the foramen. On this area, you can see the nerve. On this side here, you're unable, there's compression on the L5 nerve there. Okay, so now we have our answer. At this point, are we doing surgery, or would there be anything else that you would do before you further indicate her for surgery, Dr. Yoon?
Yeah, let me make some comment about interpreting these images. I think they're very difficult to understand exactly what's happening to the L5 nerve root with just these kinds of slices. So if you look at the panel on the left-hand side, if you can point out the right-sided L5 nerve root, which is, that one right there, that smear right there, that's the right L5 nerve root, right? And then you can see that the foramen is completely open on that right side. And then you're gonna look over onto the left side foramen, where there's a nice fat patch, no more medial, start more medial. Okay. Right there. So you see that foramen is completely open. Okay, so the area in question is that kind of lateral to the foramen area, and you have to really just take multiple cuts to kind of understand what happens to the nerve root. There's a chance that nerve has already escaped before this, so you'd have to see multiple cuts. And this is the middle panel, is that the right or the left side, or foramen? The middle panel.
Oh, this panel here?
Yeah.
Here. This is the right side, the contralateral side.
Okay. And then when you look on the left side, it's really hard to see what's going on, but I can kind of sense that there might be a nerve right below the pedicle, right there, but it's hard to tell. So you'd have to see multiple cuts to see what's happening. But let's just assume that there is some foraminal stenosis, right? Okay. So the next question that I have for you is whether the symptoms are getting worse or better, and whether it's really just numbness and weakness, or is there an element of ongoing like pain kind of a component to it?
So there definitely is a radicular pain. She's, she attempted to decrease her gabapentin and had to go up due to the her radicular symptoms. And I would say the numbness doesn't seem to be a large component of the description within the notes, but it's more so the pain and then the weakness.
Yeah, so I think that it's critically important to understand what the chief complaint here is. If she's got mainly just residual numbness and weakness, and that's not getting worse, I would probably be very conservative with my approach here. But if it's truly pain in the L5 distribution, especially if it's not responding to conservative treatment, then I'd be much more aggressive here, right? And let's just assume that you see some compression of the nerve, perhaps a DRG. It's kind of hard to tell here because of the distortion of the anatomy and all that. I mean, for all I know, you see that arrow that you're pointing to on that panel there on the left?
Yes.
Yeah, right there. There could be that could be a nerve already out there that's on the ala of the sacrum. But my point, I guess, is that when you're trying to treat these folks, I try to be very conservative with numbness and static weakness, but for pain, more aggressive. So the first things that, beyond what you've done already, that I would recommend is to do a selective nerve root block of L5 and see how they respond to that. And if they do respond well, there you go. Then I think you might have more, what do you call it? More likely to do something. But even then, I'd be super careful here, very careful.
Yes, so as you suggested, that was our next step, and given the 70% improvement in the pain and her feeling her gait was improved as well, so maybe associated, maybe her gait's off because of weakness, but maybe also there's the pain component as well, we did indicate her for surgery. And so now that we've indicated her for surgery, what is your approach in terms of decompression versus decompression infusion, and then approach for the decompression itself? Because as you noted, we are lateral in terms of the area of stenosis.
It looks like the fragment is coming off the pedicle, and then on that middle panel, and then on the right-hand panel, it looks like it's coming off the SAP. Is that right? Of L5. That's what it looks like. Yeah.
Lateral pedicle. Sort of the pedicle, lateral pedicle, or the junction of the pedicle and SAP.
Okay. All right. So that area is not the kind of area that we typically going to work in as spine surgeons. So it is a bit unusual, and it is right next to the nerve, so you'd have to be careful. But I think it's definitely reachable by a posterior-only approach. And I think if you're comfortable doing this through a tube, I think this might be something that you could try doing that. If not, then I would just do kind of a Wiltsey approach and just try to remove the osteophyte without trying to do any fusions or anything like that. Because that bony osteophyte, removing that does not compromise the stability of the spine at all. So for instance, it doesn't affect the facet joints, which is, so that's not going to be compromised. The disc is not going to be compromised. So I would treat it like a bone spur, so to speak, and just try to remove that.
Awesome. Well, that is exactly what we did. I agree. Given that, like you said, it doesn't affect stability, we can do decompression. Given the lateral location of it, we decided to do, spine surgeon decided to do an outside to-end decompression through a navigated technique. So this is just kind of a picture of the setup sorry, I'm wrong. Let's go. Oh, sorry, gave it away. But this is the frame set up here. This is just showing how small the incision could be, and so these are the patient's legs. This is her back, just to kind of orient everyone. And so did a initial O-arm spin and then another O-arm spin, and what you can see here, and I'll wrap it up, is that this is the initial pre, and then post, this is just an air fluid level. You can see that bone has been resected. And these are some additional images to show the differences, the post.
So I have two questions.
Yes.
One, the technique of how it was done. Did you use an osteotome, or did you try to burr it all off?
So I guess from the setup through the resection, so we did navigation. I don't think I would have been comfortable doing this without navigation because, as you said, that root is right under that block of bone we're taking out. We're going right at it. So I think that was helpful. I used a navigated Midas, so a 3mm matchstick, which is navigated and very accurate typically for a case like this. And then the Sonopet, which is similar to bone scalpel. So Sonopet with basically a diamond cutting tip.
Yeah, so for those of you who are not spine surgeons, one of the things that we don't want to usually, quote unquote, dick around with is the is the dorsal root ganglion. That thing has memory. If you mess with it, the patients will hurt for a very long time, and you'll regret that you've done the surgery. So I would have been very careful to warn the patient ahead of time about that.
Yeah.
Because no matter what technique you use, you're going to be irritating the DRG to some degree there.
Yeah.
So I'd be super careful about that. Then my next question is, how did the patient do?
So we picked cases from within the last 6 weeks. So she's still, I think, 10 days post-op. So we doing well.
Great.
But I think the things I worry about with this are, even though I don't think she had Bertolotti's per se before, it's sort of a Bertolotti's, but morphology now. And so classically with Bertolotti's resections, they have more motion post-op than they do pre-op. So could she have back pain from the increased motion? Neurologically, she did great. So we monitored the case, used direct nerve stim, so we knew exactly when we were getting close to the nerve. Didn't have any warnings in surgery or anything. So remains to be seen, I think, from a back pain standpoint, but from a neurologic standpoint, she's doing great.
Very interesting case.
Okay. Awesome. Thank you guys so much for your participation, everyone. Thank you to Dr. June and Dr. Schmidt for having this lively discussion. And see, everyone's spine can be really exciting. And next up, we have one of my amazing co-residents, PGY4, Dr. Sarah Shroud, who's going to do our next case. Thank you.
Nice job.
Hi, good morning, everyone. I'm Sarah Stroud. I'm also a PGY4. I just matched into trauma. And our case now is focused on a patient with a lateral plateau fracture. So he's 52. He is a physiologically young, healthy guy. He slipped and fell a day prior to presentation, chasing a mugger. That day, his pain was quite stable. He had slow progressive foot numbness, and he decided to present when he woke up the next morning because he was unable to move his toes. He is a photographer. He has no toxic habits. Here's his exam on admission. He was resting quite comfortably, was very conversant. He didn't require IV pain meds when we were examining him. His compartments were swollen but compressible. He did have valgus instability and extension. And notably, he had a foot drop. He had some numbness in SP, but no other distributions, and no significant pain with passive stretch. His foot was warm and well perfused with a palpable pulse. Here are his x-rays, which show this displaced, depressed lateral plateau fracture with condylar widening. And before we move on, I thought we could just go back and hear your thoughts about his exam.
Assume that question's directed at me. What's
Yes.
what's the number one thing on your list of concerns?
Yeah, so I mean, the number one concern is obviously compartment syndrome.
Yeah. So this is not a case that fits any of the classic ones.
Mm-hmm.
I have a patient I'm following in my clinic, almost the exact same fracture. It was a woman who just stepping on off a step stool in her kitchen,
Mm-hmm.
and just thought she'd sprained something, and delayed her presentation. She was a stoic person and came in with similar symptoms.
Mm-hmm.
And our ER docs attributed her foot drop to a primary injury to a peroneal nerve.
Yeah.
Which, if you think about it, is for a lateral plateau doesn't necessarily make sense mechanistically. But anyway, so they were in no rush to consult us, and I think it was 12 hours before all the imaging was done. This is during a time when our ER was really overflowing with staffing issues and all these other things last fall. She had a completely dead anterior compartment by the time we got to her, and but it was only the anterior compartment. So the idea about whether things are compressible or not is really, I think, fraught. These are images you just have to think about it. And I was sliding my compartment syndrome talks. Its diagnosis is really suspicion and vigilance,
Yeah.
and that's about the best we can do. So you've got to really think about it first, and then watch for changes in signs. But when there's a delay in presentation, it may already be, the signs may already have progressed where you're not going to. You have to certainly think about that. And what's typically the next step if you have a clinical concern? E2's back there. What do you do if you have an injury in the clinical concern of compartment syndrome? Or is there anything to do?
Let's see who's back there.
Any-
Jeffrey. Jeffrey, go.
Anything objective at all you can get? Yeah, compartment pressure measurement. And that also is, so that typically just reinforces the concern that because it's always going to be high. Yeah, you're gonna end up going to surgery. So, I believe in the concept of perfusion pressure, but I don't think there's a single number that you can use. And we've done some interesting research on that. It's not specific at all. It's sensitive. So you'll pick up cases, but you'll pick up a lot of cases who don't have compartment syndrome and maybe subject the patient to an unnecessary fasciotomy. So when you've got the Schatzker 5 or 6 and the papers on the radiographic signs, if there's a displacement of the mechanical axis of the leg or widening of the plateau, and those are the things that really alert your suspicion. Cases like this, very few of us are going to be suspicious, and especially the folks in an urgent care or an emergency room will be probably less suspicious than we might be. So I am worried that might be what's going on, or even though it's not an injury where you'd ever honestly expect it. But
Could I ask you a question? I mean, the patient is resting comfortably without any IV pain medication, and I think it said, no pain with passive whatever. It just does not seem like to have a tremendous amount of pain. Given that scenario, how suspicious are you for compartment syndrome here? I mean,
yeah, pain is the hallmark of the diagnosis. There's certainly lots of case reports of people that apparently had it without a lot of pain. Pain is just, again, so subjective. This person I saw who definitely had a dead compartment, waited a couple of days to come in and didn't seem to be in much pain either. She just had a week, she just couldn't dorsiflex her ankle in her. So pain is difficult. And again, if we have confirmation, we're really subject to confirmation bias, I think, when we're diagnosing compartment syndrome. I'm going to talk a little about that tomorrow. In general, you kind of make up your mind, and then you pay attention to the things that support what you already have decided and ignore the things that don't. And these are the kind of things with compartment syndrome, or in any medical diagnosis, where we're trying to make decisions on incomplete information, and in this case, something where there is no truly diagnostic test. So yeah, the pain complaints and the fact that there's no pain with passive stretch reassure you, but the neurologic symptoms worry you without another explanation. And
so you would get a compartment measurement regardless?
I hardly ever measure compartment. So Dr. asked me if I get compartment pressure measurements, and I hardly ever do because they're just always a little bit high, as I said, and you rely on.
So you go to fasciotomy then?
Would I go to fasciotomy? Yeah, that's an interesting thing too, because I'm coming to think that by the time we diagnose compartment syndrome, it may be too late in many cases for fasciotomy to help, but we actually may be causing more harm. All the literature about compartment syndrome is actually the problems of doing a fasciotomy too late. And with the heroin epidemic, this is really interesting. We don't operate on a lot of those patients who have clearly undiagnosed and untreated compartment syndrome, and their outcomes aren't that bad. Sure, they have some sequelae, but they don't have amputations and then chronic infections, and their kidneys recover. And so that's a whole other question too. So I don't know, even with what you're saying, whether this person has compartment syndrome or not, but it is near at the top of the list, and I think you want to I think the best thing is to follow the person really closely for progressions and signs, and you have to compare one leg to the other, so you don't just look at the injured leg, because I've had patients say that they don't have numbness, and then when I touch the other leg and say, well, how does it feel compared to your normal foot?
Thank you. So that's exactly what we did. We admitted for very close monitoring. They were getting on the order of 1.5 hour to 2 hour checks. We got a pre-op CT given the valgus instability and the condylar widening. This patient's exam did progress. He began to develop increasing pain. He required IV pain medications, and he developed DP numbness. We then decided to striker him. And here are his compartment pressures relative to his diastolic. The anterior compartment, obviously diagnostic based on our typical criteria. The lateral compartment was measured a few times. It measured 60 once and then 15. So I thought we could also pause here and talk about our diagnostic modalities and then next steps.
Yeah, these are all really interesting questions. So, pressure measurements, the hallmark of diagnosing compartment syndrome. The Academy did convened a group of experts 5 or 6 years ago, and we came up with clinical practice guide. When you go through that process, you ask questions, just like this. Sorry, and try to find what there is that might provide an answer. And we evaluated almost 4,000 papers and came up with a grand total of, I think, 20. Thanks. 20 papers to kind of create evidence on. That's because all the papers that were thrown out were review articles or just the quality of the paper was just so poor that it really wasn't good evidence. And so I think we had 12 or 13 questions, and 7 or 8 of them just ended up being expert panel consensus. But that was the role of pressure measurements was one that we had some moderate literature on, which was really one paper, the paper from Dr. Ms. McQueen and Court Brown and colleagues in Scotland. And the paper looked at the diagnostic sensitivity and specificity of pressure measurement. So the only thing we could come up with was that it assists in the diagnosis, but you can't come up with any real standardized criteria. A delta P of 30 has been generally accepted, but it's really, we're looking at it from the opposite side. We're looking at it's good at telling you who does not have a compartment syndrome. And when it's abnormal, it doesn't necessarily mean that they do. Biomarkers is fascinating. I personally think that's where we're going to end up in diagnosing. We've just got to find what biomarker and how we can measure it, and you have to have a point of care. It doesn't help if you have to send it off to the Mayo Clinic and get it back 2 weeks later. There's a lot of research going on. There's a fascinating group over in Sweden doing some fascinating work on myoglobin, actually. But again, is it going to be best in ruling it out, like pressure, or is it, we need something that's going to help rule it in? We need a specific test. We have lots of sensitive tests. Additional diagnostic modalities is fascinating too. We used near-infrared spectroscopy in one of our metric studies and just found it just didn't work. You could get signals some of the time, but not enough to really make it of value. But we don't know if it's just the nature of the technology that we used or whether there's some fundamental problem. I truly think in an injured limb, it's going to be hard to get a transcutaneous signal like that with all the hematoma that's everywhere. But pH is something that's promising that people are looking at. So there's a lot of research being done, but nothing has risen up to, be of clinical value.
And any thoughts on ultrasound before we move on?
There is a pressure-related ultrasound technology. There's a company in Switzerland that has a device, some other things, and that's a way to sort of objectify, the pressure, just feeling and seeing how compressible it is. And with ultrasound, you put a sustained pressure, I think 10 millimeters of mercury, and it measures the width of the muscle, and then you press to 80, and it measures, and you can compare that to the normal limb, and it correlates with pressure really well. Mm-hmm. But again, whether that is going to be of diagnostic value is yet to be determined.
Andy, can I ask you a question? I think you can. This is going, but for those in the audience of us who take call and are in this kind of gray zone, watching patients who we think are at high risk, is there any clinical intervention that we can undertake? I mean, the leg was elevated and iced. Is there any evidence to support that any of that affects the natural history of a limb that's at risk for compartment syndrome?
The evidence is just really poor. There is some stuff on cryotherapy, and it kind of makes sense that might help. In terms of elevating, the teaching is you keep it at kind of level of the heart, because you don't want to keep it dependent and increase the venous pressure or raise it too high and decrease the arterial pressure. But no one really knows what's ideal, I think. And we have a hyperbaric oxygen center at my hospital, and we've sort of talked with the ER in certain cases where we think a patient's at high risk. Should we try doing those sort of things? There's evidence that may help in injuries with a lot of crushing component. Small volume resuscitation with hypertonic saline, hypertonic fluid resuscitation works for crush injuries, for traumatic brain injuries, those things. I've always wondered whether it might help in compartment syndrome. But it's all just theory and some animal studies mostly.
As a spine surgeon, I thought immediately this foot drop was related to something like a disc herniation. The patients with acute disc herniation with foot drop, they have a tremendous amount of pain. So it'd be extremely rare for this to fit the clinical picture. I have a couple of questions. Why is this person unable to fire his, extensor muscles at all? Is it because of the pain, or is he truly just kind of paralyzed? And then the other question is there any role for anti-inflammatories to try to reduce the swelling in someone in the early course of this kind of a problem?
Yeah, and that's a great point, the last one about anti-inflammatories, because they did some work in Canada, again, in animal models that shows that you can really, in a model of compartment syndrome, ameliorate a lot of the cytotoxic damage by giving early doses of anti-inflammatories. So there are a lot of things we might do, blast them with hypertonic saline and Toradol and ice and all sorts of things. We might be able to slow down the progression, but we need something like a biomarker, to monitor whether those therapeutic interventions are actually helping or not, and something that's easier to check if it's progressing than someone's pain level. It's so hard, when someone has an underlying fracture, how are you ever going to assess their pain very accurately?
Yeah, absolutely. So at this point, next step for this gentleman.
Well, based on your clinical exam findings, we'd take him to the operating room for fasciotomy.
So that's exactly what we did. We rushed him to the OR. He underwent a single incision fasciotomy, and the findings are there. I'll just briefly summarize. His anterior and lateral compartments were significantly contused and minimally reactive. His posterior compartments were both healthy, non-contused, and very contractile. He was managed with serial INDs and VAC changes, and finally underwent ORIF and delayed primary closure in the same operation on day 11. Here are his final films. Those antibiotic beads and those implants were removed about 9 months after injury when he had a healed fracture and underwent posterior tibialis tendon transfer. That actually has allowed him to bike and ambulate without an AFO at this time, as his exam had not changed previously between fasciotomy and that time. And at this point, I thought we could review the time course of his management and start with a focus on, as you alluded to earlier, when does the morbidity of fasciotomy exceed its utility?
Well, at some point, I think it certainly does. These colleagues in Sweden I was alluding to, that I was at their meeting last year, and one of their surgeons was talking about the fact that fasciotomy has never been subjected to a randomized clinical trial, which is, when he first said that, I was like, how could you even do that? But it really got me thinking, because it's just one of these dogmatic things that you have to do a fasciotomy, and certainly in the right patient, a properly timed fasciotomy will help. But there's so much morbidity to it, and once the muscle is necrotic, it's been ischemic for more than 6 to 8 hours or whatever, and there's permanent damage, it may not help. There's a misconception, I think, for some of these heroin addicts and some of the crush injuries among our general surgery colleagues, at least at my center, that if they're showing any signs of renal failure, you need to release the compartment to mitigate that. But that actually isn't true. And if you open and release someone who's got significant muscle necrosis, you'll be flooding them with all sorts of electrolytes and other toxins that you can even precipitate, sudden cardiac arrest. And we've had patients on dialysis who recover. So I think anytime there's muscle necrosis of a significant enough volume, it's too late. But we have no way to know that really right now. And if there are neurologic findings, how to differentiate them from primary direct muscle trauma, fracture displacement or the moment of injury, or maybe they tweak their back too. But that's probably the number one question, I think, is how do we know when it's too late?
And one of our thoughts in this case was that the fasciotomy may have been protective for his deep posterior compartment, which allowed the eventual tendon transfer.
Yeah.
Andy, can I add a question? This inevitably occupies a lot of time at meetings when people talk about the delayed compartment syndrome issue and missed compartments and when has it been missed. And some argue that if the pressure is still elevated, because we don't have a good way of really assessing the degree of compartmental necrosis. If the pressure is still elevated, one can assume that there's still ongoing injury, and that if you go in and you strike her as they did this patient, and you've got an elevated compartment and a low delta P, that you can still affect the course of this process. But that if the pressure were not elevated, then the cat was really out of the bag and there's no point of going in. What do you think of that line of thinking?
Clearly pressures will rise and then fall. And if you just get a single striker, one data point, you don't know where you are anywhere in that curve. If it's, maybe you're picking it at the worst and you actually don't have to do anything, maybe it's just starting. So I do believe if you're going to measure pressures, you probably should do it continuously. And we don't have a device that really, well, there's one device now that does facilitate that, but we haven't had good devices, and your hospital may not have device available to, and you can always rig up something. But yeah, I think, I mean, the high pressures are, so you're going to have elevated pressure, the muscles are going to become ischemic, it's going to eventually, all the high energy phosphate will be gone and it'll die, and it won't be salvageable. But the pressures, in my mind, the pressures are going to stay high for a while before they drop. So I think there is a period when the damage is done, the muscle's no longer salvageable, but the pressures are still high. But they're probably, level or coming down at that point.
Right. So if we know the slope, which we have that device available to us now. If we know the slope, that might, and that's still not an evidence-based recommendation, but that's my thinking too, is that if you've got a positive slope, or it's plateauing, you still may be able to affect change. But if you've got it on the wane, then probably no.
Yeah. Well, thanks.
In retrospect, given that the patient comes in with a foot drop, and you've got all this suspicion for compartment syndrome, would you want to pull the trigger to do the fasciotomy sooner than this happened in retrospect,
Yeah, I mean, hindsight's always 20/20. So when but even that's another thing. When you do a fasciotomy, you see op notes where the muscle escaped and all this kind of stuff, and we can't tell a properly timed fasciotomy from one that wasn't really necessary, because by definition the muscle all looks good, and you don't know what was going to happen in an alternate universe had you not done the fasciotomy. But yeah, it gets back to the suspicion thing. In this case, it's not an injury where honestly this person shouldn't have got a compartment syndrome.
Right. We're so biased by our prior probability, right? And lateral plateaus. I mean, all of us struggle to remember one that got a compartment syndrome. Yeah. So
the case that we had,
some bias.
Was very much like this. When she finally got to the OR, and she was probably more than 24 hours post-injury at that point, but her entire anterior compartment was dead and just was completely excised, and the wound was immediately closed. And she actually did remarkably well. I just saw her. I just took her hardware out last week. She's now 2 years post-injury, and she had a little discomfort over the plate, but she had a tendon transfer. She doesn't have active dorsiflexion, but her foot is plantigrade, and she doesn't run or anything. But you all probably heard the news about the $111 million lawsuit in Minnesota a year ago for missed compartment syndrome. It was a tibial plateau fracture in a soccer player, and had a tibial nailing, sort of in a ambulatory surgery center, and discharged home. And
nice. Maybe one more question, and then we should probably move on to the next case. Alfred.
On that note, given the lack of evidence and consensus, is there something in terms of medical legal advice you can provide to all of us taking call?
Yeah. Yeah, this is the most. I think this entity and pediatric femoral shaft fractures are the most common reasons for litigation against certainly orthopedic trauma surgeons, maybe all orthopedics, but I think it's well documented that we don't document. Notes just don't have complete exams. Sometimes they're not timed. I get cases to review every so often, and you're reading through the chart, and we know what we should be documenting, but it just isn't documented. And then the decision making isn't documented. I think if you have the evidence and you document your assessment and why you made the decision you did, you ought to be okay, I think the judgments like the one I just referred to come, because things aren't documented in the chart, and you can't tell that the doc says in deposition, well, I was seeing the person and I was watching them, but they didn't write notes. So it's things like that. Yeah, I think you just have to be really circumspect. We actually have in our EPIC EHR a compartment syndrome flow sheet, where every person, whether they're general surgery, emergency surgery, us, anytime someone sees that patient, they document in the same flow sheet. Then you can compare, and I think it's really important. We try to have the same person examining the person. So it's great to see the person every hour, but it should be the same person too, because it's just not helpful to have a different person examining them every hour.
Well, thanks so much for a great discussion, everybody. I'll turn it over to Hunter Warwick.
Thank you.
Good. Fantastic.
Alrighty. Hello, everyone. For those who don't know me, my name is Hunter Warwick. I'm also one of the R4s here. I'll be going into arthroplasty. We have a recent case here from San Francisco General, but I think it touches on some nice talking points. Get my control on this. Alrighty. So this is JW, a 58-year-old male presenting with right hip pain after a fall in a parking lot. No past medical history. He has a well-functioning right total hip that was done in 2019. He works as a project manager, doesn't have any bad habits. On exam, he has tenderness palpation about the right hip, and he's distally neurovascularly intact. These are the x-rays we initially got in the emergency department. As you can see, there's a vertically oriented femoral neck fracture on the right. These are a little bit closer up images on the AP as well as the lateral. So Dr. Schmidt, at this point, is there any further workup you would do prior to making a treatment decision for this patient?
Yeah, can you just back up
Of course.
a second? I wanted to see the imaging again. So I think, that's about as vertical. It's almost beyond vertical as it can get. And if you said a 59-year-old.
Yes, 58.
Yeah.
Yes, sir.
So, and I'm going to talk about this later this morning. At our center, with a femoral neck fracture in this age group, the topic of should they have, it's not really about non-operative treatment. They're going to have something. But should it be fixation or an arthroplasty? And that's because femoral neck fractures in general have such a bad outcome. Having said that, though, vertical fractures are clearly a different animal, and they require they're biomechanically different. They probably require different fixation strategies. Certainly than a transcervical or a fracture that's not so vertical, with a Powell's angle that's less. But I think Corey Collins is a orthotrauma surgeon who's talked a lot about this injury. And one thing I think that we neglect in this is assessment of what the plane of the fracture is in the sagittal plane. We look at the AP X-ray and we look at it in the coronal plane and we measure its verticality. But one of the tenets of fracture, making a fracture stable is you compress it. But if it's oblique in the sagittal plane and you try to compress it, it's just going to shear and slide. And you probably really can't compress it. And Corey points out that this is one of the fractures we have the worst outcomes with. Yet we hardly ever get CT scans, whereas we get a CT scan at the drop of a hat in any other, complex fracture. So I would get a CT scan, I think, to help with decision making. And I think often you can look at the lateral X-ray and see if the obliquity of the fracture line. I'm having a hard time even seeing the fracture in that one, though. So, but I think it comes down to shared decision making with a patient. You've got to use a biomechanically stronger construct. Typically, with these, we're doing a kind of DHS device. A lot of people are now plating these fractures. We don't have a lot of experience with that at our center. I'm sure you hear about the pros and cons of open and closed reduction.
Yeah, we'll definitely get into all that good stuff here. So you mentioned CT scan. Most trauma patients with hip fractures, at least that type of hip fracture, come in with a CT scan from a full trauma workup. This was a relatively low energy mechanism, so we did not, but we did elect to get full-length femur films,
and so is good.
Which did not show any additional injury. And then we did get a CT scan of his right hip. So this is marching anterior to posterior here, from left to right. And then we also got some 3D reconstructions with nicely display the fracture here.
Yeah, so that'll certainly help you understand the fracture. If this were someone, 30s or 40s, I think you're probably going to fix it. And these types of fractures, whether you use the horizontal kind of the Weber screw or you use a DHS screw, I do think an open reduction with a plate kind of placed right at the apex of the fracture immediately is helpful. But there's the literature on that is very new, and it's certainly you can get a good reduction that way. You can buttress it, but I don't think we fully understand if the outcomes are better if you do that or not. I think the more interesting argument, which we'll talk about later, is the fixation versus arthroplasty argument, because with a primary total hip in that age group, they can expect a fairly durable outcome and a good result and immediate weight bearing and all those things, which you can't really give them with fixation right away. They used to be saying that the only place for an arthroplasty was in a bucket, and the patients could keep their femoral head. But the outcomes are pretty impressive with arthroplasty in the older patients. And again, but the vertical fractures are a subset where we don't have good evidence on that necessarily either.
Is this amenable to a straightforward primary total hip, or are you looking at a more calcar replacing type of femoral component?
No, I think for me, I'd be able to use my standard stem. I use a kind of a tapered ingrowth stem in most of my joints, and if there's posterior comminution down at and below the lesser trochanter, then I'm doing a taper fluted stem, but usually a short one.
Excellent. So I think it'd be nice to kind of go into if we end up doing arthroplasty, the pros and cons of THA versus hemiarthroplasty, and then if you pursue total hip arthroplasty in the femoral neck fracture setting, are you using dual mobility implants?
Sometimes, not all the time, because it adds expense to the case, and that's also I'm a little wary of new technology. Not that it's necessarily new, that new, but if this person I probably would not. But if you've got an older person with cognitive, problems or Parkinson's, or there just seem like there's additional risks for dislocation. They kind of additive, I think, than I might. But I'm a little worried about we just don't know the really long-term results of the dual mobility constructs and how well they do in the long run in terms of wear, osteolysis, other things that might happen.
Andy, what do you think the results? How do you square the results of the health trial and this question mark about total hips, which I think a lot of people had assumed were better? If you were going to do an arthroplasty, why not give them the best arthroplasty straight away?
Yeah, that is the argument, and I'm also wary of just repeated sub-analyses of a trial that are done over and over again. So I've heard Emil talk about some of those follow-up papers on the health trial, and we were a site. We contributed, like a lot of those multi-center studies, just a handful of patients to it. Yeah, I think the literature, there's got to be close to 20 large randomized clinical trials now of fixation versus total hip, and then some have a hemiarthroplasty arm for femoral neck fractures, and they generally all come out strongly in favor of the total hip. But even then, you still see one that comes to an opposite conclusion. So the evidence is still not perfect, but it's strong. And this is a case where I would have a discussion with the patient and kind of that shared decision-making concept that it's this person could go either way.
Yeah.
It really depends on the skills of the surgeon. And at a place like ours, we've got people that can do both really well. And some patients are strongly in favor of getting back to work quickly and not facing reoperation, which is probably the thing I think is the biggest difference. There's hardly any reoperation after a total, whereas there is with either a hemi or a fixation. But other patients they don't want a hip don't want anything artificial in their bodies, is what they say.
Yeah, I mean, I think if folks out here have not read Corey's recent paper, and we had a paper prior to that which showed a 20 to 25% major reoperation rate. The larger study by Corey's group showed, I mean, it was like in the high 40s major reoperation rate for young femoral necks treated with operative fixation, whether they were closed reduced or open reduced or, the type of fixation construct. So really, I mean, that's why he, and I think a lot of us think it's about as bad as anything we treat in orthopedic trauma.
Absolutely. And then kind of moving down our talking points here. So if you were to pursue fixation in this patient, what are your thoughts on open versus closed reduction and your fixation construct?
Yeah, I think this is the fracture that benefits from an open reduction. I think it's with a transcervical fracture or others, patterns of femoral neck fracture. Maybe the jury's out, and the paper that Sam did, which we also contributed a couple of patients to, showed that actually results with open reduction might be a little bit worse. But I think this fracture is going to really demand that. You've got it. This is a fracture where the reduction's got to be, I think, perfect. I think you probably really do. You need some fixation down at the apex of that fracture, whether it's a little buttress plate or a compression screw or something. But I do think I would open this one if the patient shows fixation. I would open it. I'd do a little medial neck plate. Do an anterior Smith-Peet approach, a medial buttress plate, and then probably a DHS type of a device.
Excellent. And do you have thoughts on the FAITH trial with, in terms of canoid hip screws versus CHS? I know the sub-analyses showed that this type of fracture pattern might be more, amenable to a sliding hip screw.
Yeah, cantilevered screws are just simply not going to work in a vertical fracture like this. There's really no way they can biomechanically. Yeah.
Excellent. Alrighty, thank you for that. So this patient went to the operating room. Closed reduction was attempted with a distal femoral traction, seen in the top left there. That was unsuccessful, so a percutaneous shoulder hook was used to pull the femoral neck fragment laterally, which resulted in a nice reduction. Yeah. That was held with K-wires, and then a DHS was placed and compression provided across it. And then a derotational screw was also placed and was lagged by technique for some additional compression there.
Looks really good. Yeah, that bone hook trick is really nice. I do that a lot in some of these kind of pertrochanteric subtroch fractures we get, and then the head is flexed and, up in Verne sometimes, and you can just slide that hook around and grab right where you did, and the problem is you got to have someone hold it the whole case. Yeah. No, but that looks great. Yeah.
And you mentioned the CT scan to look at the sagittal plane. And are you orienting your fixation differently, A to P, based on what you see at the CT to be more perpendicular? Is that possible? Is there enough?
Yeah. So if the fracture is oblique in that sagittal plane, then ideally you would change the fixation to be perpendicular, but you really can't. And I mean, if it's only 5 degrees, you probably could, but maybe that's not it. The problem is if it's 20 or 30 degrees, there's just no way to do it. Yeah, especially with a DHS. You might be able to put a lag screw across it or something to hold, but then you get conflict in space for your implants. I think it's an important prognostic factor, for failure of fixation that we haven't looked at real well.
Yeah, as I look at this fracture anatomy, think about it, it's like the worst case scenario. We've got a biomechanically challenging pattern for the reasons we just discussed, and then it also exits right where the blood supply enters the head. So we're kind of really starting off in a tough situation to fix.
So Andy, you would have done a replacement.
Well, Dr. just asked if I would have done a replacement. So I would have talked to the patient, and if that's what he wanted, yeah. Would I be leaning? Well, as a fracture surgeon, I love doing cases like this, fixing things. Yeah, this is then as a joint surgeon, you get the immediate gratification of watching someone walk in the clinic the next week. That's the balance I'm going to talk about in a couple hours. Yeah.
If it was your hip.
If this was my hip, man, that's a tough question. Because I'm older than I give myself credit for being. I'm the next decade now, so probably should have a total. But when the rubber met the road and someone asked me that question, if I was in this situation, I don't know what I would say.
Who's standing in front of you?
Yeah, it would.
If Sam Moore said, I'd let him fix it.
Yeah.
Jeff Barry was in the emergency room, I'd tell him to replace it.
Yeah. 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 And it's how the question is framed by the person who's given me the options too.
All right. Well, thank you, Dr. Schmidt. Appreciate all of that. I'd like to invite Dr. O'Donnell up for the next case.
Good morning, everyone. I'm Jen O'Donnell, another one of our PGY4s. I'm going to be doing fellowship at Emory in spine. Okay, great. So I have another spine case for us. So this was a 68-year-old male who had come in and presented with chief complaint of kind of vague complaints, back pain, trouble standing, keeping himself upright, felt like he was leaning forward, as well as leg pain. Of note, he had a history of 5 prior spine surgeries at an outside hospital. And his exam otherwise did not have any red flags, any changes in bowel or bladder. He also has a history of CLL, which is in remission, and some kind of run-of-the-mill things. This weight loss was attributed to the leukemia. He was a smoker but had quit. And so here are his past surgical history. It started off with a discectomy, went on to fusion at that level, fusion at the adjacent level, fusion at the next adjacent level, and then a revision surgery as well. And so on exam, he is leaning forward quite a bit and no neurological deficits. And so here's his films when he came to us. As you can see, he has a fusion from L3 to S1. And then we also have an MRI. So this is a mid-sagittal cut. And you can note that he has adjacent level stenosis now at L2-3. This is L1-2, and this is L2-3. And so he has central stenosis as well as bilateral foraminal stenosis here. Worse on the left, although he does not have worse symptoms on one leg or the other. Pretty much pain going down both legs. So then we have our EOS total spine x-rays. This helps us with assessing sagittal imbalance. As you can see, there's loss of lumbar lordosis. Pelvic tilt is not terrible, but it's important to note that his entire lumbar spine from L3 to S1 is now rigidly fixed in these angles. And then you can also see from his SVA, he's leaning quite a bit forward, and for him, this is the most bothersome part.
So
I'll
Jen,
stop
can I
here.
stop
Yeah.
you there? Good. Very nice. So let's try to make it more interactive and engaging. Maybe you start with the junior residents again. PGY2s, raise your hands, please. I think we heard from both of you. You just got 2 PGY2s here. So I'm sorry, what's your name over there? Ryan, okay. What's the diagnosis for this patient? Clinical diagnosis. We can lateral to the other resident then if he's. What's your name?
I'm Jeffrey.
Jeffrey, okay. You heard the story.
Yeah.
Okay. So they comes in, you probably basically you need just a few bits of information to have a really good idea of what's going on, right? You need their age and their chief complaint. And that's a really good start to getting a good diagnosis. So 60-something-year-old, and the chief complaint was unable to reach overhead and having trouble standing up straight.
Yep.
So what do you think?
Yeah, so there's a sagittal imbalance and then also mismatch.
Right, that's anatomic. So, but clinically speaking, he sounds like he's got what? Kind of a flat back syndrome kind of picture, doesn't it? Doesn't that what it sounds like?
Yes.
Okay, so what else would you be, trying to, what else sort kind of a story would you be eliciting, trying to elicit from a patient like this, you think?
Does he get tired after standing up straight? Does he use assistive devices?
There you go, great question. So that would be, does the patient have neurogenic claudication?
Yeah, he's not using any assistive devices. And then as far as neurogenic claudication, no, he didn't complain of any numbness.
So neurogenic claudication being like worse, pain in the legs when standing, right? So that's not due to vascular origin. So that's what we're thinking about. So those are the kind of the histories that you really want to go, because spine surgery is not about the X-rays and the MRIs. It's really trying to understand what the patient's chief complaints are for you to get your best results. Okay, so in summary, the patient's got a flat back, right, from all the multiple surgeries, and so is unable to stand in a very erect posture, right? So the way you get standing X-rays, it has to be standardized at each institution. What we try to do is try to get them standing upright as much as possible, and trying to get them to extend their hips and knees maximally. And the beauty of these EOS machines, which you have, which I don't have, I'm a little jealous about that, is that you can see the full length, and you can tell whether the patient's hips and knees are flexed or not. So that's great. So this person definitely has a sagittal plane deformity. And then in terms of the stenosis, it was kind of hard for me to tell because of the T1 images right there.
Yeah.
Yeah, but I'll take your word for it.
Yeah.
Okay.
So I'll chime in. He does have, complaints of leg pain with walking around. So I would say he does have neurogenic claudication. So a mixture, presenting with a mixture of leg pain, which at that time was his primary complaint, and then the postural symptoms. Yeah.
Great. So at this point, the patient has two issues. He has the adjacent level stenosis at L2-3, and he has this flat back syndrome. It was discussed with the patient kind of at length. Do you want to try to address only the L2-3 symptoms and see how that goes? It's a smaller surgery, or do a larger extension of the fusion and osteotomy with that. And we kind of discussed a little bit about flat back syndrome and deformity. And obviously this patient had also had multiple surgeries kind of progressing down the lumbar spine, and now is presenting with this larger issue. So I think it's a conversation that you have to have with the patient. In this case, the patient elected to go with the smaller surgery, so a decompression was done. After surgery, his leg pain was slightly resolved, but the back pain continued. Not much long after surgery, the patient already was wishing to go forward with the larger surgery. And so here's his post-operative films from the extension. As I put on the previous slide, it's T11 to pelvis it was extended to, and a PSO pedicle subtraction osteotomy was done at L4. So any thoughts on, for this construct, what things you're thinking about, Dr. Yoon?
So I think this is a really interesting case, right? So as a person's got lumbar stenosis, and lumbar stenosis in and of itself can prevent a patient from being able to stand up straight. So without actually having any rigid deformity, they will have this kind of hunchback forward position, they're walking like this, looking like they've got flat back. And if they've been in that position for a long time, they've kind of like taught themselves to walk in that kind of a position. So it's hard to tell if they truly have a rigid flat back or not. So that's a scenario where here and you're trying to determine, can you do a laminectomy, which is outpatient surgery, versus doing a big osteotomy, which is a huge surgery with significant risk. I mean, that's the choice that we're facing. And so I think that is a challenging situation. And again, this is one of these things where if the patient is capable, I think it's very useful to do the shared decision-making kind of process. And I think that to involve the patient, make it, his choice. I think there's a chance that if he has a significant amount of neurogenic claudication, that he might get some relief out of the situation. But I probably would not have done just a simple laminectomy. And my reasoning is this, is that he's had multiple surgeries, so he's got a long, stiff segment up to the L2-3 level. And the reason why it's degenerated and stenosed is because of that instability pattern in the facet joints. And usually they don't respond very well to just a laminectomy. And I'm going to show some cases in my talk that talks about this problem, the adjacent segment problem. And I've really moved towards fusing those. And so I would have probably done a one-level procedure or a bigger procedure. That would have been the choice that I would have offered the patient. And then, yeah, go ahead.
I would say I completely agree. So I would say me too. However, the patient said in no uncertain terms, I do not want another fusion. So we kind of ended up in this back and forth a bit, and this is what he elected to do.
And that one little piece where you're trying to correct getting any additional lordosis, or are you just trying to fuse that painful segment? Because you can't get much of a correction from that one level.
Right. I'm going to show you some slides on how you can do this on my coming up talk. So this is great. It's a nice little teaser for the audience. But yeah, I would try to get some correction at that focal segment, and there are many different ways to do that. But yeah, I would. But I would also tell that person that one-level procedure is probably not enough. That 12 centimeters, I think, is that what it was?
Yeah, 12 centimeters.
Yeah, yeah, that's probably not enough. There's too much of a mismatch there.
And just to point out one more thing on the X-ray, the PILL mismatch is not enormous. So that's, I think, something we're learning more about these low pelvic incidence patients, is that plus minus 10 is probably not adequate, or at least minus 10 lumbar lordosis to pelvic incidence is probably not adequate for the low PI patient.
Yeah, my philosophy about this is the first thing you got to look at is the SVA. How much are they actually physically leaning forward? Mm-hmm. And then that's the number one parameter to look at. And then number two would be the PILL mismatch. Yeah. So for those of you who are not spine surgeons, that's, the degree of lordosis that's required is set by the shape of the pelvis. So that has to match well enough. But I think that's secondary to the forward pitch, the C2 SVA.
Great. And I'll show kind of just side by side where he started and where we ended here. And patient is about 8 weeks post-op now from this larger surgery. He's had a little bit of back pain, leg pain kind of coming and going, but as of last week was doing pretty well for where he is post-op.
How many weeks post-op?
About 8 right now.
Okay.
So we shall see. Great. I think that's all for me now. Thank you.
Thank you.
Good morning. Thank you both for being here today. My name is Matt Churches. I'm one of the fourth years as well. I'll be headed to Emory next year as well for arthroplasty. So for case number 5, we'll be talking about geriatric acetabular fractures and kind of different approaches to managing it. So briefly, this is an 89-year-old gentleman with a ground level fall 3 days prior onto his left hip who was unable to ambulate due to persistent pain while out dancing with friends. Finally presented 3 days after the fall to the ED and otherwise denied any numbness, weakness, or tingling. The rest of his history was non-contributory. And for activities, he's actually a very active 89-year-old, likes to go out dancing with friends, daily walker, and lives independently. Focused exam of his left lower extremity showed a shortened left leg with intact skin and ecchymosis noted over the left hip. He was unable to weight bear or range the hip and had significant pain with log roll. He was otherwise distally neurovascularly intact without pain in any other joint or extremity. So initial AP pelvis films here shown upon presentation to the ED when focusing on the left hip are notable for disruption of both the ilioischial and iliopectineal lines. And you can see the medialization of the left femoral head through the quadrilateral surface. So just briefly want to pause for a second. Given that he's 3 days out from his fall, is there any additional medical workup or radiographic workup that you would consider, Dr. Schmidt?
Well, we would get the full workup we would do in a young trauma patient in terms of imaging. Mm-hmm. The G2s have been beat up too much. How about a G3? What's kind of the pelvic trauma imaging protocol?
Get a CT out pelvis with contrast to just evaluate for bleeding in the pelvis.
Yeah, and I was thinking the inlet outlet and Judet views are really helpful as well. We like to try to, you can basically diagnose the pelvic fracture and even tell a lot about the pattern even just from the AP pelvis, so you start with that. But yeah, the inlet or the Judet views are very helpful. And I get more information out of those a lot of times than the CT scan, but for certain fracture patterns, there are things that they can only see in a CT scan. What images do we got? We got AP, basically AP pelvis, and there's the CT.
Just skipping straight to, there was a full radiographic workup, but for the sake of time, we'll skip straight to the CT scan. Yeah. So these are axial images here, again showing combination at the joint line, as well as that medialization of the femoral head. And then we have some sample coronal images here that show marginal impaction at the fracture site, and again, that medialization of the femoral head.
May I just ask a question for the trauma group? How worried are you for DVTs in this patient, and would you do something to look for pelvic DVTs specifically?
We don't look for pelvic DVTs specifically. We put them all on 5,000 units of heparin, TID. We don't use. We're more comfortable with that than Lovenox in these patients that are at a significant bleeding risk, but they are at a significant DVT risk also. That's always the balance. If there's been a delay in diagnosis or treatment for whatever reason, they were perhaps in a nursing home and just didn't get sent in or whatever, then we often do ultrasounds, and look for venous lower extremity ultrasound.
So him being 3 days out from the injury, that...
We just put him on the heparin protocol and just do the standard imaging. But that's a good question. What do you all do? Do you have a different?
Well, I'm a tumor surgeon, so I send these to someone else. But
yeah, and that's another big risk factor for DVT.
Yeah, right. So we do look for them in our patients because they have elevated risk factors.
Right. We believe strongly in the family history, personal history of DVT, and if they've got that, we'll probably look a little bit more. But normally we don't do anything other than just mechanical foot pumps and heparin. The fracture pattern is pretty typical. Dr. Yoon was asking about aspirin. We don't usually use that pre-op. We do that a lot post-op because it's so safe. And I think I'm aware of some recent data that aspirin is as effective as the more aggressive regimens, even in high-risk patients. But that's another thing we struggle with, is what to do with them after surgery. Yeah, so this is kind of like the femoral neck fracture. So you got these talks are clearly customized to what I'm interested in, so I appreciate that. Yeah. So what's the outcome of this going to be with non-operative treatment? Is it going to be okay or not? A lot of heads are shaking like this.
It's not going to be okay.
Yeah. And so Some people will treat these patients with non-operative management, bed rest, and that's going to ruin this guy's life. He can't go out and dance, and probably never will again. So I think that's a precept. This is like a femoral neck fracture, proximal femur fracture, and these acetabular fractures. Whatever you do, you've got to mobilize the patient. And maybe there are some patients that can be mobilized with an injury like this, and be treated non-operatively, but they're very few and far between. I have seen some people with fractures like this that were neglected and survive, and they come in and you can get a total hip done later. And that's the problem: is how do you do a total hip when there's no solid foundation bone to put the total hip in? And then that begs the question: well, someone who's expert at fixing these fractures, and I see a lot of acetabular fracture surgeons who will fix fractures like this, and there's even some papers showing some pretty good results and specialized techniques that you use. But I think one really fascinating question is the concept of impaction. So what are two reasons why that head might look displaced? So impaction being one. Is there another explanation? So just a non-impacted fracture that can be reduced and fixed. So that's one, because Jeff Anglin wrote a paper about the goal sign and talking about the poor prognosis of someone that has impaction of the acetabular roof. But some of the fractures doesn't say, well, it's not really impacted; it's just a fragment, and I can put that fragment back and reduce it and fix it and all those things. So I think that is a legitimate question. But so the signs of impaction would be like a plateau fracture, where you can see kind of the cancellous bone is condensed, and you can see that there's not a whole fragment that's moved. It's like a lateral plateau. But this is the kind of case where and the cognitive aspect, the cognitive function of the patient is really important, I think, too, because you really do need to find out what their functional expectations are, what their functional demands are. Many patients in this age group aren't really making their own decisions anymore, so you're dealing with a family member, and they have all those family dynamics come into play with that. How would you classify this fracture?
Yeah. So given the complete dissociation of the acetabulum from the intact ilium, you can see here on that third image, moving left to right, this was classified as an associated both column acetabular fracture. And I know it's hard when we can't scroll through the images, right. But with just static snapshots here.
Yeah, well, certainly, one thing I always look at is the status of the posterior wall. So sometimes you'll see, the most common pattern in this age group is the anterior column posterior hemitransverse. So in the back it looks like a transverse, but sometimes you'll see posterior wall involvement. But what's different about a both column fracture than any other acetabular fracture? What separates it from?
The joint is kind of free floating, separated from the rest of the pelvis, kind of circumferentially.
So two things follow from that. That fact does lead to that concept of secondary congruency that you sometimes see. Mm-hmm. So sometimes you'll see these fractures and the hip actually is pretty congruent, and if the patient can pass a trial of kind of getting up and moving, maybe they'll be okay, but this hip isn't really particularly congruent. And I think the middle panel on the top, you can see, that roof is impacted, and you already pointed out how it's medialized. But if you're thinking of trying to do a total hip, that same feature, there's, by definition, every single piece of bone that you're going to try to be putting your cup into is a fracture piece that's potentially unstable. So we've had an approach that I'm going to talk about later at our center. This is a good segue to that. But you can do arthroplasty in these cases. You can fix them. It probably comes down to who the surgeon is that's talking to the patient, what his or her capabilities are. I can tell you at our center, Dave Templeman would fix all of these, but when the patient fell, his first question is, did the patient fall from a standing height? Because if they fell from a standing height and had a fracture like this, by definition, they have profound osteopenia. And even if you can get a reduction, it's just really hard to maintain the reduction, especially if you're going to mobilize the patient, which is the whole goal.
And I think we touched on a good number of these, and it sounds like we'll hear more about it later. But I just wanted to briefly ask for these: if someone is very frail, elderly, and medically sick, do you think there's any role for percutaneous fixation, or if you're going to fix it, you're going to open it up and put it back together?
Yeah, no, there's definitely a role for that. There's some surgeons, again, who are real good at that, doing percutaneous fixation. And that's, I think, particularly germane to this age group for the exact reasons you said. The morbidity of surgery is huge. We've had a couple patients with significant bleeding, from the anterior approach. So if you can, if you're facile with those closure reduction techniques, and maybe you have Adam Starr's table, and you put them in traction and do all these maneuvers, and you can target those screws and understand where to put them. I think that is a good in between for these patients that might allow them to be mobilized. They may not be perfect, but if they can survive this, they've kind of survived their stress test and they heal. And a malunion doesn't really matter when you're doing a total hip. You can deal with that. It's just having a stable construct, a scaffold. Yeah.
Just add that this ABC pattern is really challenging with percutaneous techniques. I mean, in lesser column injuries, when you have a cranial anterior posterior column to fix into, that may make more sense. You don't have that here, so I think perc is off the table for this patient.
Yeah, for this particular pattern, yeah, I would agree, and we don't do a lot of that at our place either.
So moving on to what was actually done. Sorry, was there a question?
Dr. Yoon was asking about the role of navigation in these cases. So we don't, at our place, C-arm. But if you've got, if you're facile with those techniques and have access to it, especially if you're going to do percutaneous things. But it's hard to create a percutaneous construct in this particular pattern because you have nothing to start with.
Yeah, and so after a long discussion with the patient and discussing both fixing it as well as arthroplasty, the decision was made to take a dual approach just to get him mobilizing, given his activity level pre-injury. So they started off by fixing this ABC through a modified stappa and lateral window, and then went posterior and performed a total hip arthroplasty, a hybrid total hip with a cemented femoral stem. So final x-rays here show interval reduction of his associated both column fracture, and then a well-sized, fixed, and positioned hybrid total hip arthroplasty. So just to kind of keep the conversation going, what are your thoughts on these simultaneous or dual approaches of both fixing and then replacing in the same operation? Is it safe? Is it effective? And then does the subacute versus chronic nature of an injury change your approach?
Yeah, so we do find the simultaneous approach to be helpful, and I'll show our data in the talk I'm giving later this morning. But we do this. Our tenet has been to fix the fracture based on the pattern. So and the anterior column is very often involved in these cases. So some sort of anterior approach we find to be very helpful. And we found that your goals of surgery are a lot different in this age group than a young person. You're not trying to reduce the articular surface. You're just trying to create something stable that'll hold the cup in place. And we found you can often just use even the lateral window, iliac fossa, and you can expose that in 5 to 10 minutes pretty easily, and put a plate there with a couple long posterior column screws if you're able, and just buttress that part. The quadrilateral plate, if it's really displaced, the anterior intrapelvic approach is great for that. And with those quadrilateral plates like you showed here, we've had some bleeding problems in a couple of instances in those cases, and I think there's a paper that just was talking about that too. Obviously the vascular anatomy is variable in that area, and there's a lot of bony bleeding as well. So I think you want to be experienced at that approach in younger patients before you try it on an older person. But you can do it quickly is the point. If you're facile with an anterior total hip, you can even incorporate that approach into a Smith-Pete or something, and or do some sort of an anterior approach total hip. I'm much more confident with posterior. That's what I use for my primary, so we will just do the simultaneous approach and almost always the same day. And we've had low complication rate doing that.
Question?
Sorry, quick question. Was that a dual geometry that you used?
I actually don't know which implant was used. This was done down at San Jose Regional, and I don't have access to that EMR. So this was all kind of relayed through a different surgeon.
All right.
Sorry.
So can you tell us a little bit about the patient's post-op course?
Yeah. Post-op day 0, he was transferred back to the floor, stable. Post-op day 1, he did well. Again, hemodynamically stable. He was able to actually mobilize to the edge of bed and actually stand. Unfortunately, on post-op day 2, there was an aspiration event with coffee ground emesis. Code blue was called and ACLS was initiated. Unfortunately, he was unable to be resuscitated and passed away on post-op day 2. So again, kind of begs the question, does the high-risk nature of this dual approach of both fixing and then replacing kind of limit some enthusiasm for the early mobilization in this frail population?
These are very, very frail patients, no doubt about that. But this particular complication you could see happen in almost regardless of how you treated the patient. I mean, it wasn't directly a surgical complication. We're fond of this approach in this age group in very selected patients because it does allow them to mobilize. And that is so important to, I think, avoiding complications, just like the femoral neck fractures. We know, really 24 hours. Literature probably better supports 48 hours, but I think the sooner the better. And I think it's the same for these. There's some question though whether operating really affects the overall mortality. I think there's one paper that says it doesn't, and others that maybe you are improving mortality by mobilizing them. Mm-hmm. But no doubt it's a risky population. But yeah. Dr. Yun, you were going to ask a question.
Yeah, in the spine world, we have a lot of trouble with osteoporotic patients and gaining fixation and being able to hold it when the bone is that soft. So we try really to augment things. You've seen cement as one option you've seen today, but also things like Forteo. So 3 months of Forteo in a patient pre-op seems to make a difference. I'm just wondering about how you approach that in this kind of situation.
Yeah, we don't have a lot of good options. Obviously you can't do the pre-op medical optimization in a trauma type case like this. You can certainly use cement. You can some of that rapid setting calcium phosphate cements. You can fill a defect in. You can drill into. We've done some of those things rarely to push down some of those defects. More so when we're trying to fix the fracture than replacing. Because when you're doing a total hip, you can just bone graft. Use the patient's femoral head and bone graft and kind of do an impaction grafting to fill in any defects. And there's a lot of techniques you can use for doing the total hip. Ours has been very similar to what that case was, but there's some people that do cages. There's dual cups. Well, they'll put a press fit cup in and kind of do a distraction, arthroplasty, and then put bone graft in and put another cup in outside of that. These crazy looking X-rays. So the Europeans seem to be fond of that kind of cup in a cage sort of technique, but. Yeah, that is the issue, is the osteopenia and then, of course, the fracture.
Matt, can you go back to your post-reduction X-ray? Not with the total hip. Yeah, I'm looking at that thinking, wow.
Looks pretty good.
You've done a pretty good job. Why do a total hip? Are you just assuming the cartilage is going to melt away?
Yeah, I mean, our experience shows that the head just settles back where it was. That's, I don't know if there's an intraoperative traction going on there or not, but there might have been. Yeah, it'll typically.
Degree of comminution that will.
Yeah, that roof was impacted and was sort of disimpacted. I don't see that there's any cement or anything up in there, but that's what we would try to, if we're fixing the case. We disinfect the roof, and there's a bone void just like in a plateau, and try to put something up in there. And we had some cases where we used that balloon, that kyphosis balloon, to push the roof down and then create a bone void that's very well defined, and you can try to fill it. We had success with that in a couple cases, but yeah, I thought the same thing when I saw that. That reduction is pretty good, but that's the problem. It just doesn't stay. The femoral head just medializes again, and.
I think we're going to try to wrap up here and go on break and come back in 15 minutes. I had one last question is, what was the weight-bearing status after that surgery?
Yeah, so he was weight-bearing as tolerated and was actually able to stand up at bedside following the surgery post-op day 1. He did not ambulate at all, but was able to actually get up, whereas for the 3 days prior to presentation, he was bedbound.
And there's more to come on osteoporosis, so that was another teaser for later this afternoon. Okay, we'll see you back in 15 minutes.